So my name's Simon Judkins, and I'm the Clinical Director of the Emergency Department at Austin Health, but also in a role at the College of Emergency Medicine. I'm the President-elect of the College, we've obviously been very involved in processes and procedures around misdiagnoses for a number of different reasons. Obviously, in my clinical role, that's incredibly important, not only from the patient perspective, but I've had a particular interest along the way around the secondary victims as well, and how misdiagnoses actually impact on the staff involved in that as well. So, I approach it from a number of different perspectives. And certainly then in the role of the College of Emergency Medicine, it's a big issue as well, because, there are system factors, obviously, that, I'm concerned about that will contribute to, misdiagnosis at the coalface. And so in that role, I'm strongly involved in, advocacy around resources for emergency departments, looking at staffing levels, looking at stress levels. So, misdiagnosis in itself, when you unpack it, there's a lot of different issues that lead to that sort of final error. That's where my interest lies is about the system issues as well. There's a couple of things. I think we're getting bigger and busier. There's certainly a supply and demand issue. As I said, we're seeing increasing patient numbers, but at the same time we're grappling with a workforce that we don't think is keeping pace with that demand. We have lots of junior nursing staff and junior doctors, so in a very hectic environment, we're trying to teach, train, supervise junior staff as well, and so that's incredibly challenging. And more, I think one of the things that I'm concerned about, and a lot of my colleagues are concerned about, is that more and more the emergency department seems to be becoming the diagnostic unit for the rest of the hospital as well. And so, I'm really concerned that the way we staff and manage the hospital isn't really keeping pace with the way our communities, when they demand or when they need their care. So this concept of a 24/7 hospital, we've been talking about that for a long time, and there's still a lot of gaps there. So we know that there's more error rates after hours, we know on long weekends, we know on weekends. And so more and more, I think the way that the hospital manages risk is that they want everything done down in the ED, which again then puts more pressure on emergency department doctors as well. So that's another really a concern that I have. So I think I've done some work in regional hospitals as well, and so I visit Albury Health Service, for example, and I'm recently been involved working on the board at Castlemaine Health. And again, I think some of the areas we really need to look at goes back to the staffing models also, because we all know that while our junior medical staff do lots of rotations in regional and rural areas, we don't see the same level of senior staff in those areas. There's very much a visiting medical officer model in those areas. So there is a concern that I suppose, again, as those places get busier, and that we all know that they are, that staffing model hasn't kept pace with those changes as well. So I think that's a problem. The solution is, I think we do need to look at the way we run those regional and rural emergency departments, looking at the staffing models, but also I think developing stronger links between regional and rural departments and larger hospitals as well. At the moment, in Victoria at least, it's a very much devolved model, and I think developing stronger links between different facilities to enable information sharing, clinical pathways, sharing of staffing models, those sorts of things will go a long way towards contributing to providing a solution. The reporting through Riskman from an emergency department is low. I think it needs to be improved. Certainly we get reports, most of our reports are done after the events, and we don't report enough on missed events or near misses. So I think that's a real problem as well. So we're only reporting when we recognise that something bad has happened. We're certainly not reporting enough on near misses. And I think if we're not reporting on near misses, then we're going nowhere near recognising the extent of what the problem could be. Because a near miss, one that just gets saved at the last minute by somebody intervening, is just as much of a concern as a miss, I think. So we need to do a lot more reporting around that. I think for emergency medicine, emergency department staff, it's an issue around time and the convenience, I suppose, of sitting down and filling in a Riskman. And in all honesty, I think a lot of my staff say that's going to take me 15 minutes. I've got patients to see, and so we need probably a more effective and efficient system for reporting errors and near misses.